Next slide. So this is a mouthful, so I'm not going to read it, but I do want to introduce you to our two speakers. So Dr. Michelle Wong is a physician, a nephrologist, and a clinical assistant professor in the Department of Medicine and the Division of Nephrology at UBC. She's a clinical researcher who's been focusing on the complications of CKD, including protein energy wasting, anemia, volume overload, and hypertension. She's very active in the International Society of Nephrology, is a member of the North American and Caribbean Regional Board and the Emerging Leaders Program in the first 2021 cohort, and also partakes in the Kidney Health Professionals Working Group. She's also part of the Canadian Nephrology Clinical Trials Network Communications and Engagement Committee, and she's leading interprofessional research program in renal nutrition here in BC, along with Danny Renouf, Tanya Choy, and many others. And joining her is Tanya Choy, who's a registered dietitian for over 14 years in the public and private sectors. She's the interim clinical resource dietitian at St. Paul's Hospital, the interim executive chair of the Provincial Renal Dietitians Group, and a clinical instructor at UBC. She too is actively involved in many aspects of kidney care, advocacy, and patient education, but works with the media at the Kidney Foundation of Canada, as well as local news outlets, to make sure that people eat well in the context of kidney disease. She also runs her own private practice. And so with that, I think we have a diverse panel today, and hopefully we'll learn a lot about what we thought we knew and what we need to now know about nutrition and kidney disease. I'm going to hand it over to you. Thanks very much for joining us, everybody.
Great. Thanks, Adira, for that introduction. And I hope you can see my screen and presentation.
No problem.
Mode.
Perfect.
Great. Thank you. So today, Tanya and I are going to be talking about these three interrelated topics: plant-based diets, gut microbiota, and potassium, and how we're implementing a new approach to dietary potassium management in kidney patients. And this will give us an opportunity to highlight some of our up-and-coming research and other initiatives. So our learning objectives for today: first, to understand the relationship between diet and the gut microbiota in mediating CKD progression and other health outcomes. And two, to understand the potential benefits of plant-based nutrition in the CKD population. I'll be covering these two objectives, and then Tanya will be covering the last two objectives, which are to understand and apply the new approach to potassium management in CKD, and also to show you some newly available resources for patients and healthcare professionals regarding potassium management. And first, I just wanted to give you a snapshot of our BC Renal Nutrition Research Program. Our previous work has focused on characterizing nutritional status and protein energy wasting in non-dialysis and hemodialysis patients, as well as the transition to hemodialysis. And we've also done a lot of evaluation of our oral nutritional supplement program, and this program has recently expanded to include all post-transplant patients. Our newer work is regarding diet and CKD progression. So we have a systematic review of type of protein and quantity of fruit and vegetable intake. And BC sites will, in the future, participate in an RCT of fruit and vegetable delivery. And under the gut microbiota sphere, we have a upcoming new prospective cohort study to characterize gut microbiota composition and functional profiles in patients with protein energy wasting, and as well people without protein energy wasting. And we also have been developing implementation tools for dietary approaches to management of hyperkalemia. And this is directed at healthcare providers and patients. And as well, we are currently writing a commentary on diet and planetary health. And we have an ongoing initiative with the ISN and the ISRNM to develop educational webinars for improving renal nutrition care in low resource settings. So today I'm going to be talking about those 3 topics there with the stars and highlighting some of our new research. So first of all, gut microbiome research is a growing field. It's implicated in many chronic diseases, not just chronic kidney disease, but also gastrointestinal disorders, diabetes, autoimmune disease, neurologic disorders. And you might have heard about the Microseta initiative, which originally started as the American Gut Project and the British Gut Project. This is the world's largest citizen science microbiome project. And you might have also heard about Biomass, which is a data portal where microbiome profiles can be shared from epidemiology studies. And there's a lot of interest from the general public about how to harness the microbiome to improve their health. And so just a few definitions. The microbiota refers to the community of microorganisms that occupy a particular environment. And the microbiome includes the microbiota plus its theater of activity, which includes their collective genomes and their structural elements, as well as the metabolites that they produce and their surrounding environment. And to describe microbiota, we assess diversity. So there's taxonomic diversity, which looks at richness, which refers to the total number of species present, as well as evenness, which is the relative differences in abundance of each species. And you can look at alpha diversity, which is the diversity within a sample, as well as beta diversity, which compares diversity between pairs of samples. You can also look at functional diversity, which allows us to look at the array of metabolic activities in the community of microbiota. So in humans, there are about 100 trillion microbes, which are predominantly bacteria, in the gut, and they interact with the human host. In terms of the beneficial interactions, the anaerobic gut bacteria produce short-chain fatty acids through saccharolytic fermentation of resistant carbohydrates. So these are the fibers. And short-chain fatty acids have a lot of health benefits. So on the right there, you can see propionate, butyrate, acetate. Those are common short-chain fatty acids produced. They help with maintaining gut barrier. The butyrate is an energy source for the enterocytes. They improve the mucus production and the integrity of the tight junctions in the enterocytes. They also are involved with regulating insulin release and appetite, as well as cholesterol metabolism, and they have anti-inflammatory effects. Oh, sorry, and gut bacteria also synthesize vitamins and produce amino acids. So metabolism dependent and immune dependent pathways mediate this gut-kidney axis. And in CKD, there's often dysbiosis, which means there's an imbalance in the microbiota, which favor more proteolytic bacteria. And these bacteria produce metabolites or uremic toxins, indicated here in the blue boxes as P-cresol and indoxyl sulfates. And when there is dysbiotic microbiota, there's a disruption of the intestinal barrier, and these uremic toxins and endotoxins can enter the circulation and affect kidneys by inducing fibrosis and increasing inflammation. So the inflammatory pathway is shown here in the green boxes here. And there's an interaction between these two pathways. So in addition to affecting the kidneys, the gut microbiota and their metabolites also affect metabolism and increase the risk of obesity and metabolic syndrome, as well as the cardiovascular system. And so gut microbiota can contribute to this triad of cardio-renal metabolic disease. Gut microbiota are influenced by multiple factors, and I've listed a whole bunch of things there on the left. So we know that disease affects the gut microbiota, diet can affect the microbiota. As mentioned, fiber is a favorable, has a favorable effect on the gut microbiota. but protein artificial sweeteners may cause dysbiosis. Medications can also affect the gut microbiota. Metformin has a favorable effect on the gut microbiota, but the other medications listed here, like antibiotics, proton pump inhibitors, iron, phosphate binders, may adversely affect the gut microbiota. Nutritional status, such as malnutrition and obesity, those things can also adversely affect microbiota. Age, hormones, the environment, and genetic factors tend to play a minor role. It's mainly environmental and other factors that influence the gut microbiota. So chronic kidney disease is associated with gut dysbiosis, and there are many factors that lead to this. There's often low fiber intake, which causes reduced gut motility. There's metabolic derangements such as metabolic acidosis, the medications that I mentioned, as well as increased intestinal excretion of urea, uric acid, and oxalate. So this leads to lower bacterial diversity in persons with CKD and an altered composition of bacteria. So there's more proteobacteria and bacteria with urease, uricase, and tryptophanase activity. This can increase inflammation, uremic toxins, and endotoxemia. And as indicated there on the right, you see the impaired intestinal barrier and the endotoxemia with the LPS being released into the circulation, and the protein fermentation, which leads to the production of these uremic toxins. You also have reduced bacteria that produce short-chain fatty acids. So this includes the bifidobacteria, lactobacillus, Faecalibacterium. So this is the derangement that you might see in the gut microbiota in someone with chronic kidney disease. So diet does play a large role in affecting the gut microbiota through multiple pathways. So you see on the left, whole plant foods have dietary fibers. This increases the production of short chain fatty acids. And so this improves the enterocyte gut barrier, reduces the pathogenic bacterial taxa, and improves homeostatic regulation of immune and endocrine function. And so short chain fatty acids reduce inflammation, and phenolic metabolites from cruciferous vegetables or fermented foods can also increase NRF2, which activates antioxidant enzymes. On the right, you see the processed foods. And so this tends to be a low fiber diet, and therefore reduced production of short chain fatty acids. And this also promotes the increase in pathogenic bacterial taxa and an unfavorable gut microbiota environment, such that there is immune dysregulation and endocrine dysregulation, which increases the risk of chronic kidney disease and other chronic diseases. Endotoxins can increase inflammation and uremic toxins as well. It's thought that it goes through NF-kappa beta to increase inflammation in the body. So trimethylamine N-oxide, or TMAO for short, is a gut-derived metabolite that's associated with adverse clinical outcomes. And it or TMA, the precursor, is produced by gut microbiota during metabolism of phosphatidylcholine and L-carnitine, of which red meat, eggs, dairy products, and saltwater fish are rich sources. In CKD, dysbiosis favors TMA formation over other metabolic pathways, and then TMAO is formed in the liver. And higher levels of TMAO are associated with increased inflammation, reduced kidney function, increased mortality, as well as increase in ischemic events. So this is a good example of how gut microbiota can cause adverse clinical outcomes through their production of uremic toxins. And finally, we know that nutritional status affects gut microbiota composition. So our prior research is in protein energy wasting, which is a complication of chronic kidney disease that results in a loss of muscle mass and fat mass. Causes of protein energy wasting include not only reduced intake, but the uremic milieu, comorbidities, metabolic derangements, and inflammation. And it has many adverse consequences, including cardiovascular disease, infection, reduced quality of life, and increased risk of mortality. And so protein energy wasting is associated with altered gut microbiota composition in dialysis. There are two studies from China. The study on the left was in hemodialysis patients, and this shows the differentially abundant species. So the species in green are in higher abundance in normal nutritional status, and the species in red are in higher abundance in protein energy wasting. And we know that in patients with protein energy wasting, there's lower alpha diversity. They found that there was a lower abundance of short chain fatty acid producing bacteria in these patients with protein energy wasting. And on the right, this is a study in CAPD patients. In the red boxes, you see the species that are more abundant in the patients who are malnourished. And there's a Clostridium bacteria that was correlated with lower serum albumin, prealbumin, and worse subjective global assessment. So it is closely associated with nutritional status. And interestingly, there's an Akkermansia bacteria, which was positively correlated with overhydration. And this Akkermansia bacteria was also found in abundance in the hemodialysis patients in the other study as well. But there have been no studies in non-dialysis CKD, so therefore we aim to address this gap with a new research study. We've called this Describing the Gut Microbiota in People with Non-Dialysis CKD, a Step Towards Precision Nutrition. And so we aim to answer three main questions. Number one, are gut microbiota composition and short chain fatty acid levels altered by nutritional status and dietary intake in people with non-dialysis CKD? Could treatment with oral nutritional supplements alter the gut microbiota composition and short chain fatty acid levels in patients with protein energy wasting? And three, how do gut microbiota and short chain fatty acid metabolite compositions associate with progression of kidney disease? So to answer this, we are going to be doing a prospective cohort study with a nested case control study with 50 cases with protein energy wasting and 50 controls with normal nutritional status at 2 of the kidney care clinic sites in Vancouver. And we'll be collecting samples at baseline in 2 years of blood, urine, and stool, as well as doing detailed nutritional assessments. And you see on the right is a stool kit where patients can collect their stool samples at home using this kit. And gut microbiota composition and functional profiles will be assessed using shallow shotgun metagenomic sequencing done at Microbiome Insights, which is a local microbiome lab. So this is up and coming, and very excited to launch research in this area. And I'm going to transition now to plant-based diets. And so I've shown you that gut microbiota profile is more favorable with diets with increased fiber, and this provides a putative mechanism by which plant-based diets may exert health benefits. The topic of dietary strategies to reduce risk of progression of chronic kidney disease has been identified by patients and caregivers as a research priority. And so to this end, there is much interest in this topic of plant-based diets. So a plant-based diet refers to eating patterns that include large proportion of plant-based foods. So some examples here: flexitarian, vegetarian, vegan, Mediterranean diet, DASH diet. And Plato and Plafond. So these are plant-dominant, low-protein diets. Generally, low protein refers to 0.6 to 0.8 grams of protein per kilogram of body weight per day, and plant-dominant referring to more than 50% of the protein source as being plant-based. So we'll talk a little bit more about that in a moment. These Plato and Plafond diets are CKD specific. And so just to give examples of plant-based sources of protein versus animal sources of protein, on the left, the plant-based sources include soy, vegetable, beans and legumes, lentils, seeds, nuts, and animal sources includes meat, seafood, dairy, and eggs. But it is important to be aware that a plant-based diet could still be unhealthy. So you see there, an unhealthy plant-based diet might be highly processed or have a lot of refined grains and additives. And a healthy plant-based diet has a lot of whole food ingredients and more vitamins and minerals. So it's important to keep that in mind. So protein intake can affect the filtration and intraglomerular pressure. So low protein diet can reduce intraglomerular pressure by modulating the afferent arterial tone, and this reduces the hyperfiltration. And this is in synergy to the reduction in intraglomerular pressure seen with SGLT2 inhibitors and RAS inhibitors. And you may ask, does the type of protein affect the intraglomerular pressure differently? And so to answer this question, this was addressed in normal or healthy volunteers in an old study from 1990, and essentially they showed that with the vegetable protein diet, there was less hyperfiltration observed than with animal protein diet, and this is shown on the right here. And there are a lot of potential benefits of plant-based diets, so it does have pleiotropic effects. So on the left, in terms of the causes of CKD and the comorbidities we often see in people with CKD, plant-based diets can reduce blood pressure, reduce obesity, improve glycemic control. It can also help with alleviating CKD complications. So there's less hyperphosphatemia because there's less bioavailable phosphorus in plant-based foods. In plant-based foods and whole grains, phosphate is in the form of phytate, and this is less bioavailable because humans lack phytase, which is the enzyme that breaks down phytate. And so therefore, vegetarian sources of protein generally have 10 to 30% GI absorption of phosphorus compared to 46% in animals and 80 to 100% when there's phosphate additives. There's also reduced acidosis. As you know, fruits and vegetables are generally base producing, and this can in turn help to reduce the risk of hyperkalemia. And then plant-based diets can reduce constipation because increased fiber intake promotes fecal potassium excretion as well. And in terms of CKD progression outcomes, there's reduced risk of kidney progression through hyperfiltration, through beneficial gut microbiota profile effects. And it can reduce albuminuria. There have been some observational studies that showed a reduced risk of mortality when there is more plant-based protein as a total ratio compared to the total amount of total protein intake. And in planetary health-wise, it can reduce greenhouse gas emissions and water use. And at the bottom there, I listed a database of food impacts on the environment for linking to diets. So this is a database of foods if you want to check the effects on the environment with different types of foods. And so This slide here just shows potential concerns about plant-based nutrition and how to address these concerns. So first of all, I put the fear of the risk of hyperkalemia at the top, because we know that from research studies, there is actually a very weak association between the dietary potassium intake and the serum potassiums. And therefore, we really want to focus on managing the multifactorial causes of hyperkalemia and encouraging whole foods and less processed foods to address this concern. And for protein inadequacy as a potential concern, we can address that by emphasizing that the lower protein content in plant-based diets can help to achieve the protein intake targets. And as long as we encourage a varied diet, it's very unlikely that a plant-based diet could cause any nutritional deficiencies. Thirdly, accessibility, including cost and the presence of food deserts or food swamps, which make it difficult to have healthy food choices. We have individualized dietitian counseling, and they will consider each person's individual psychosocial aspects as well. There are ministry programs for income eligible patients, including the Farmers Market Nutrition Coupon Program, which gives people easier access to fresh fruits and vegetables. And again, food literacy is another issue. Again, dietitian counseling and all the resources that dietitians have been working on to produce, including videos and patient handouts, are very helpful in this regard. There are also community teaching kitchens, including the food skills for families offered by the BC CDC. So just a quick note about protein adequacy with plant-based diets. Generally, a well-balanced and diverse plant-based diet is nutritionally adequate. So previous studies have been done in comparing vegetarian low-protein diets and animal-based low-protein diets, and there's been no difference in nutritional status, no evidence of any nutritional inadequacies in the patients with the vegetarian low-protein diets. It's important to remember that plants also contain essential amino acids, not just animal proteins, but there are differences in amino acid content, digestibility, and availability between plant and animal foods. In CKD, non-dialysis in general, supplementation with keto analogs, which are nitrogen-free analogs of the essential amino acids, are not needed if the total protein intake is at least 0.6 grams per kilogram per day. This is outlined in a nice article by Joshi et al. 2019 in the Journal of Renal Nutrition. Now, just a summary of the protein intake in chronic kidney disease guidelines as it has evolved over time. I'd just like to point out the KDIGO 2012 recommendations, which specified 0.8 grams of protein per kilogram per day for patients with GFR less than 30. And more currently, the KDOKI guidelines recommended 0.55 to 0.6 grams of protein per kilogram per day in people with GFR less than 60. And to look at that a little bit more specifically, so this is in non-dialysis patients with CKD 3 to 5 without diabetes, that they recommended the 0.55 to 0.6. Or a very low protein diet with 0.28 to 0.43 if supplemented with keto acid analogs. And they listed this as a 1A recommendation for end-stage kidney disease and death, as well as a 2C recommendation for quality of life. In patients with diabetes, there's much less evidence, but they did recommend a higher target of 0.6 to 0.8. And they mentioned there is insufficient evidence to recommend a particular protein type. Now, there is a little bit of concern that the guidelines might have overstated a bit of the evidence. When we do look at the systematic review, which was published in the same year as the guidelines, that they looked at low protein diets for non-diabetic adults with CKD. And we saw that a low protein diet compared, or a very low protein diet compared with the low protein intake or normal protein intake probably made no difference to death. So we see a non-statistically significant relative risk here. However, it does reduce end-stage kidney disease, and we see a statistically significant relative risk here of 0.64. However, there was very uncertain whether it changes or whether it influences change in GFR. It's very low certainty evidence here. So the critique of the evidence for low protein diet was that there was an incongruence between the findings for kidney failure outcome and the GFR outcome. They did not address the quality or the type of protein. And many studies are from the pre-RAS inhibitor era, in which, so it doesn't reflect current practice. And low protein diet interventions were not patient-centered. So they were very difficult to implement in real practice, potentially, and low adherence to these low protein diets. So therefore, we are currently engaging in a systematic review, which is in progress. And we have our team members here, including dietitians, nephrologists, and fellows, a medical student, and librarian. So we aim to address the type of protein and the quantity of fruit and vegetable intake on risk of kidney disease progression in patients with non-dialysis CKD. And our inclusion criteria include patients with non-dialysis CKD with a GFR of at least 15. And our interventions of interest include the type of protein intake. In particular, we're interested in diets with plant-based proteins, with or without keto analog supplements. And our second question is to look at quantity of fruit and vegetable intake. Our comparators are usual or conventional diets. And the outcomes, we're particularly interested in looking at progression to end-stage kidney disease using a composite outcome measure, as well as secondary outcomes of change in GFR, albuminuria, mortality, quality of life, serum biochemistry, A1C, blood pressure, and nutritional status. And we're looking at RCTs and observational studies with prospectively collected data, at least 30 participants, and studies that have adequate follow-up and intervention duration. So we screened over 16,000 studies, and 234 were assessed for full text eligibility. We're currently collating the included studies, and I'm just going to give you a quick snapshot of a selection of them. In general, we've got RCTs assessing soy protein and Mediterranean diets. We have a number of cohort studies as well that are general population cohort studies, but they do report on CKD sub-cohorts. There's a couple of studies that are focused on older patients. We have no evidence available for pediatric CKD population, no. And eGFR changes or slopes tend to be assessed more commonly than end-stage kidney disease. But they have a lot of recent studies that were not included in the consideration for the guidelines for the KDOQI 2020 nutrition guidelines. So there are more results to come, so stay tuned. There are also a lot of ongoing upcoming RCTs that we've identified during our search. So the first study there, the REDACT study, is being led by Dylan McKay and Nav Tangri in Winnipeg. It's a feasibility study looking at weekly fruit and vegetable home delivery versus oral alkali for patients with non-dialysis CKD and metabolic acidosis. This will be scaled up to a pan-Canadian RCT that will, BC sites will be participating in. And their primary outcome for this larger study is eGFR slope. There are also two ongoing studies, one in the US, one in Japan, looking at plant-based diets with low protein. And so we'll keep our eyes out for these new trials. And so with that, I'm going to pass it over to Tanya, who will discuss the dietary management of potassium and its evolution, as well as some of our educational strategies that we've developed.
Thank you so much, Michelle. I'm just going to share my screen. Okay, can you see my screen?
Yep.
Great. So hi, everyone. For my portion of the presentation, I'll be speaking on the new approach to potassium management and touching a bit on the evolution of how this has changed, what our current education handouts are teaching our patients and why we need to change them. And in the end, I'm going to share some resources that we have been working hard on, which better reflects what the evidence shows. So my goal at the end of the presentation is that as a team with these new resources is that we're going to have a more consistent message when it comes to potassium management for our patients. I do want to share that because we're not going to do a deep dive today, but there was a really good presentation done by my colleague, Danny Radoof, back in October of 2022, where she presented at Province-Wide Round. So I have the link there if you're interested. So going back in time with the previous potassium guidelines is that there was a specific potassium restriction in terms of number of milligrams where the potassium source was not differentiated. And with that, there was also the use of the traditional, I'll call it traditional renal diet, where there was a restriction of things like fruits and vegetables, whole grains, plant-based proteins, whereas grains that were processed or lower in fruits and vegetables with animal proteins being favored. There's also a lot of lists across different sources that categorize foods into low, medium, and high potassium. And if we look across these different sources, there's actually a lot of inconsistencies with how foods are categorized, which adds to the confusion. And I'm going to talk a little bit more about how the number of milligrams that's actually on paper for the food is not equivalent to what is actually available for absorption. So I want to speak upon how some of these restrictions have an impact on our patients. And so a systematic review of qualitative studies showed that patients with complex dietary and food restrictions are associated with worsening patient quality of life, and it had a negative impact on patients' relationships. And I believe that with my work in the clinic, patients tell me, I don't know what to eat. With the different restrictions. And further, the development of hyperkalemia was associated with significant reduced quality of life, especially those who are on dialysis. And so people are not just thinking about the quote unquote renal diet, but they're juggling multiple therapeutic diets for their diabetes or for their heart condition. They might be experiencing contradicting or incorrect or outdated information online, bombarded with diet culture, developing a negative relationship with food. So it's complicated. There's a lot to manage. So with the new KDOQI 2020 updated guidelines, it no longer has a specific amount of potassium that they're recommending. Instead, they choose to individualize it. And they do make a comment to say that there is a scarcity of studies. They found no clinical trials on how modifying diet can influence serum potassium levels in patients with CKD. And they also go on to say that factors other than dietary intake influence potassium levels. They also make a statement of promoting plant-based diets. So Michelle already talked about the Mediterranean diet and plant-based diets, but the diet patterns that are rich in fruits and vegetables and they also promote that to help with weight management, blood pressure control, and the reduction of acid production. And then furthermore, with the KDIGO updated guidelines in 2020, they also recommend an individualized diet that's rich in fruits and vegetables, whole grains, fiber, legumes, and they make a specific statement to counsel patients to avoid potassium-containing salt substitutes. They do make a sentence to say for advanced CKD, potassium may need to be restricted for certain foods. So what does the evidence say? So even though potassium restriction is often recommended to prevent and treat hyperkalemia, there's been numerous studies across different stages of CKD, including controlled trials, which show that despite eating patterns with increased dietary potassium, it's not associated with serum potassium. I did circle one study there with one patient who did have hyperkalemia, but they did have a pre-existing condition that can cause hyperkalemia. So overall, generally, it is not associated with increase in potassium from dietary sources. So on to hemodialysis patients. Unlike for pre-dialysis, it's not, I did want to point out it's not studied quite as rigorously. There's no controlled trials, mainly observational studies. But so far, even with that, the evidence available, there seems to be a weak correlation for the risk of hyperkalemia when eating plant-based diets and increasing potassium intake. So it was curious to know kind of where did this low potassium teaching come from? And it seems to have stemmed from studies back in the 1940s where people were given large doses of potassium salts either alone or in juice, like tomato juice, orange juice, carrot juice, and they were given to people with and without CKD. And so they took serial measurements of potassium, and they found that people with CKD had an impaired tolerance compared to healthy controls. It does highlight, though, that it's different in terms of taking in excessive amounts of a potassium salt versus from dietary potassium sources in unprocessed whole foods. So what are our current handouts teaching our patients? This study looked at and reviewed 18 Canadian resources and 6 additional resources from national agencies in both Canada and the US, and 100% of them recommended restriction of fruits and vegetables as the first line, and only a quarter of them mentioned restriction of potassium additives and processed food, which is a problem. And the reason for that is because Canada's consumption of ultra-processed food is on the rise. As of 2012, Health Canada put in the mandate and direction for the food industry to reduce sodium in processed food. And with potassium salts, it does provide a similar taste profile in that it tastes salty. And so in a recent report, it showed that Canadians are 50% of their energy intake is coming from processed foods, which is a large proportion. And so if a lot of these foods have potassium additives in them, that would be more of a significant source rather than from fruits and vegetables. So the biggest impact would be on cheese products, bread products, canned soups, processed meats, processed snacks. And I'm going to talk a little bit more about the bioavailability. So the difference between getting it from whole processed foods versus from salt substitutes. So what about our handouts? So this is the advanced handout from the BC Renal Agency. And as you can see, it's lists of food where it separates into low, medium, and high. And so although it is interesting to see some of these values, it may not provide a complete picture of actual dietary potassium exposure. So the milligrams on paper is not equivalent to how much is actually absorbed. So some of these lists just assume similar bioavailability of potassium throughout foods. One interesting thing is that a lot of these values were taken from the Canadian nutrient file. And what was found is that 60% of the values on the Canadian nutrient file for these numbers were taken before the year 2000. And so this was before the Health Canada mandate of in 2012, where potassium salts were starting to be introduced into the food system. And so we might be actually underestimating how much potassium is in certain processed foods. So it was interesting to see kind of what factors may mitigate the rise in serum potassium, even though we're eating plants that are rich in potassium. So there's likely multiple factors that mitigate the impact. So first of all, fiber content. So the co-ingestion of dietary fiber may lower the bioavailability, as well the alkalizing effect from plants, as well as the carbohydrate content in plants promote this insulin secretion, which helps facilitate the potassium uptake into cells and minimize the impact on serum potassium levels. We know that the bowels adapt to increase fecal potassium excretion to compensate as kidney function decreases. And so by having adequate plants with fiber, that may also help with preventing constipation and to move the bowels. Potassium in plants is within cell walls, so it actually might be more difficult to digest and explain the reduced bioavailability. And then in terms of preparation, there are different ways that even with foods that are rich in potassium, and in terms of cooking for soaking or boiling or boiling twice and throwing out the water, there are different ways to lower the potassium in foods as well. So as I spoke a little bit about why for plant foods, it's doesn't affect the serum potassium as much. And so here I've separated them into plant foods, animal based foods, and then also foods that have potassium additives. And you can see that there's a big difference in terms of the bioavailability. So for plant foods, it's up to 50–60%, so it could be lower. Whereas for animal-based proteins, they are low in carbohydrates for meat. And so it may not have as good of an ability to be able to shift the potassium into cells. And then also the net acid effect from meat results in higher amounts of potassium staying in the serum. And then hidden sources of potassium in processed foods is at 90%. So it's even higher and highly absorbable. So those are the ones that we want to be watching out for. I did want to show you what patients are looking at. So this is what for labels, I do want to point out that it's a bit small, so very difficult when people are picking up packages. It's very difficult to see for our more elderly patients or patients with poor eyesight. And however, with label reading, dietitians can really empower patients to be able to take that knowledge into their own hands to figure out, oh, does this food have potassium additives, and what can I choose instead? There's lots of different names for the potassium additives, and some of which I've listed here. And there's actually over 40 different additives that are allowed into food. So lots of potential hidden sources, many different forms. So if someone's potassium is high, often previously we would look at bananas or different foods, but looking at this, 3 slices of this deli meat already has 730 milligrams of potassium, highly absorbable, versus compared to, say, a banana of 420 milligrams, it's maybe only 50% absorbed. So there is a difference. And in addition, you'll get the benefits of the fiber and the nutrients from the banana and fruits and vegetable plant-based food. So in terms of the new approach to hyperkalemia management, there is accumulating evidence to show that a diet that is rich in plant foods, fruits and vegetables, whole grains, and plant-based protein that has vitamins, minerals, and fiber, it's associated with prevention of CKD, improvements in blood pressure, decreased risk for CVD, decreased risk for diabetes. So lots of different benefits. And so by following the traditional low potassium diet, we might be actually doing our patients a disservice from receiving these benefits of plant foods. And so we also might be inhibiting the management of their other comorbidities. So the goal is to shift from the traditional renal diet and move towards a whole unprocessed plant foods, and to make sure that is individualized with consideration as to how foods are combined, distributed throughout the day, and consider the different aspects that can affect potassium. So here I do mention just a few things that can potentially impact potassium other than food. And so it's important to kind of go through all of these different aspects before looking at fruits and vegetables. And so, for example, a large proportion of the patients that we see have diabetes. And so we know that potassium is likely to be higher in patients with poorly controlled diabetes. So instead of restricting, the goal is to have a more holistic approach with the team to manage blood sugars instead. For constipation, it's often associated with lack of fiber from plants. And so it's very common in kidney disease to have constipation. And in HD patients, it's reported to be as high as over 70%. So it's definitely important to manage constipation to prevent hyperkalemia. So there's that. And then there's also reports of case studies that show patients with and without CKD have hyperkalemia from eating high potassium foods, but these are sources mainly from processed foods and concentrated sources of potassium, for example, juices, sauces, dried fruit. So there is a difference between having an orange versus having orange juice, or tomatoes versus tomato sauce and soups or tomato juice. All right. So in trying to follow the recommendations of promoting whole and processed foods, food insecurity is very real. And per Statistics Canada, for multiple reasons, the yearly price increase for food at 11.4% rose at the fastest pace since 1981. And so patients may not actually be able to afford fresh foods. And it's definitely important to take a non-judgmental and supportive approach. And just looking at the number of visits to the food bank as of March 2022, it's increased by 15%. And with food banks, there is a lower amount of fresh and unprocessed foods available, but referral to a dietitian can help patients choose lower cost plant proteins, such as canned beans and lentils, or choose similarly nutritious frozen fruit and vegetables instead of fresh. So referral to a dietitian, we look at all these different factors to help partner with the patients to empower them, support patients in choosing foods that are individualized to their cultural food preferences, their financial means. And I just want to share the new handouts. And so I do want to credit the VGH dietitians. So thank you so much. They started this handout where they don't just focus on food, but they talk about all the other aspects. This is still in the draft version for the BCPRA potassium handout. And I wanted to share the new BC Renal Agency potassium handout. This is the advanced version, so different from the ones with the charts. And we had a potassium working group. We had multiple dietitians from the renal practice group, so thank you so much. We also included patient partners to help shape and guide us to create this handout. And it talks about the different aspects that we had discussed earlier: potassium additives, label reading, looking at concentrated forms of potassium, with whole and unprocessed plant foods being favored. So it is 4 pages, and that was on the guidance of patient partners. And what patients are saying about this is that they like this document as it gives them a sense of empowerment rather than what of consequence. And they like the words choose and try and enjoy, and that they can instead of I can't. So it was really amazing to have patient partners help shape our handout to make all these changes. So that was the potassium for patient facing. We also created a draft for a dietitian, so a clinician facing guide for potassium management that goes through key aspects of what to consider and questions to ask patients when it comes to hyperkalemia management. And so this is in draft form. If you're interested in it, it was ask your renal dietitian because they should have a copy. So back to Michelle here.
Yeah, so this is just a physician-facing tool that was developed in collaboration with 5 cardiology and nephrology societies, and I was involved in developing this. And essentially, we want to debunk potassium myths and give some practical tips that you can share with patients. So this will be released fairly imminently along with a paper, and this is part of an optimization of RAS inhibitor toolkit. So stay tuned for that. And so we are wanting to actually assess the effectiveness and implementation of this new multidisciplinary educational strategy with a cluster randomized stepped wedge RCT design. So we were able to look at patient outcomes, hyperkalemia, K-binder use, and implementation outcomes as well. So this is a proposal that we're putting forth to evaluate this new strategy.
Sorry. So sorry about that. So in summary, I just wanted to thank you for listening, and also that the gut microbiota is influenced by many different factors, as Michelle had explained, and can affect health outcomes through metabolic and immune pathways. And very excitingly, the new study aims to describe the gut microbiota in the CKD non-dialysis population with and without protein energy wasting at baseline. Michelle also explained about the plant-based nutrition. It has several potential health and environmental benefits, and our systematic review aims to assess the effect of the type of protein, quantity of fruits and vegetables, and CKD progression. And so these new resources that we're developing, some of them are in draft form, some of them are just being formatted and will be available soon, so stay tuned. And so the goal of today is just, instead of what did you eat as the first question when potassium is high, is to look at other factors that are impacting potassium. I do want to acknowledge that this is a change for both patients and healthcare providers. And in all, we hope to assess the implementation and effectiveness of using these resources in another study. So thank you to the systematic review team and all the different people who made it possible to create these potassium education materials that reflect current practice and literature.
Yeah, I want to thank you so much, Tanya and Michelle. Like, I must say that that was a lot, and sadly we don't have any time to answer the questions because it is right at the bottom of the hour. There has been a request that the nephrologists receive that all the handouts as well, and we'll figure out a way to make sure that that gets distributed directly to nephrologists and nephrologist offices. I think you're right, there's going to be a need for a lot of education. It's been a lot of years of potassium restriction. Nurses, doctors, dietitians, pharmacists, all believing that this was the right thing to do. It's really wonderful to see evidence-informed changes in practice and also generating new data. So I want to commend, all of you and the BC Renal Dietitian and Research Working Group, because I think this is so much of what we strive to do is A, no harm, and B, question dogma and then generate the answers to it. So really a lot. I'll encourage people to send their questions if they have any to Sidoni or Brenda. And I think it's really an amazing testimony to what a small group of dedicated people can really do when they try. And so I think this has been an area of interest very much to patients, but also I think understanding, the gut kidney interaction makes a biological plausibility of all of these changes that we make really important. It makes me even more dedicated to getting people off PPIs, because I really think we're doing them harm, not about their kidney disease, but maybe through the gut microbiota thing. I think there are many things that we can take away from this. So again, we will perhaps have to have a round table as opposed to a province-wide rounds with the two of you. And I want to let you know that you broke the record for 2023. You had 101 people listening at one point, so thank you. A topic really very exciting as another thing that we can do to help our patients. So thank you for all the work, and we'll get people to follow up independently, okay? But thank you, it was outstanding.
Thank you.
Thank you so much.